Having an approach to acute kidney injury is going to help you both on the test and on the wards. It's something you're going to encounter a lot, and if you have a framework for approaching kidney disease, it becomes much easier. We're going to go through my approach to acute kidney injury, then we're going to go over some of the diagnostic testing and what you'd look for on labs or imaging to help you decide what the diagnosis is, and then work through a diagnostic tree for acute kidney injury. We're not going to focus too much on any one disease. We'll sprinkle them in here and there. This is mostly an approach and what is the next best step when you identify that the creatinine is elevated. So this is how I see the kidney system. There's a pump, it's the heart, and it pushes blood through a series of pipes. And it's against resistance. So even though the kidneys are below the heart in this drawing, the kidneys are above. Something magical happens that most people don't understand inside the kidney, and out the other side comes urine. I want you to see this system as three distinct entities. That is pre-renal, post-renal, and intrarenal. And a couple of things can go wrong in pre-renal. For example, the pump could break. And a broken pump can't push against resistance. You could have a hole in the pipes, such as in a bleed or dehydration, and then there wouldn't be anything in the pipes to get there. But pipes don't necessarily need a hole, they could just be a little leaky and called third spacing. So that even though the person is volume up, the volume is not actually in the pipes. And lastly, you can have a clog in the pipes. And I'll link these to real diagnoses in a minute. Pump failure, volume down, third spacing, and clogged up pipes. On the post-renal side, it's about obstruction. On the pre-renal side, it's about not enough flow to the kidney for whatever reason. Post-renal is about obstruction. The kidney is behind the obstruction, and it's going to make urine, and it just keeps making urine. But if the flow of urine is obstructed, no urine can get out. And as more urine comes in, the system is going to distend. Post-renal is about obstruction, and that is hydroureter and hydronephrosis. The level of the obstruction is going to determine what gets distended. For example, if it's distal to the bladder would distend in both kidneys. If only the ureter is obstructed, then only one kidney will get distended. And then intrarenal. When you talk about intrarenal, you have to look at the nephron, and it's divided into three parts. First is the glomerulus, glomerulonephritis. The second part is the tubules. And damage to the tubules is acute tubular necrosis. And lastly, there's the space in between the interstitium, acute interstitial nephritis. All right, let's use this framework and start actually talking about the different diseases you might encounter. First, pre-renal. Pre-renal is about poor perfusion. You could have problems with the pump. This would be an MI or CHF. You could have leaky pipes, that is third spacing the fluid. That is partially CHF, but CHF is usually low flow. So think about the OSI. Nephrosis, nephrotic syndrome. Gastrosis, protein-losing enteropathies, or malnutrition, and cirrhosis. Things that cause the albumin to go down. You could have a hole in the pipes. That's the 4 Ds, diuresis, diarrhea, dehydration, and hemorrhage. The last one I know is not a D. And then there's the clog, And the clog is either going to be fibromuscular dysplasia, that's going to be the young woman with secondary hypertension and renal failure, versus the old guy who's got renal artery stenosis or atherosclerotic disease. Pre-renal, let's talk about post-renal. Post-renal is about obstruction. And as you go through the GU system, you'll realize that there are more things that can affect the distal system than the proximal. If you're talking about your readers, it's basically going to be cancer and stones only. If you're talking the level of the bladder, you can have cancer, stones, and a neurogenic bladder, whether from medications or from spinal cord injuries. And the level of the urethra can be cancer, stones, BPH, kinked Foley, and a whole lot more. And you'll notice that I've done this twice. Pre-renal, post-renal, then intrarenal. Why I'm doing it in that order is intentional, and you'll see why when we talk about the diagnostic algorithm. And then we have to turn back to intrarenal. There is a lot that you could have to know about intrarenal, and I'm purposely not going to tell you about it. Remember all the glomerulonephritides with their immunofluorescence pattern and their histological staining you studied for step 1? You don't have to know that for step 2. You do for the medicine boards, you do for step 1, you don't for step 2 because step 2 is more clinical and it's not going to help you on the wards either. So what I want to talk about in intrarenal are the 3 categories: glomerulonephritis, acute interstitial nephritis, and acute tubular necrosis, keying in on the things that you need to know about each one clinically. The first is glomerulonephritis. If you see glomerulonephritis, what you should be looking for on the urine is red blood cell casts. And if you see red blood cell casts, think glomerulonephritis. When you see red blood cell casts, what you want to do is make sure you rule out nephrotic syndrome, where you're looking for nephrotic range proteinuria, greater than 3.5 grams per day, increase in the cholesterol, and edema. If we're talking about acute interstitial nephritis, nephritis being an itis, you expect to see inflammatory cells. Look for white blood cell casts, just white blood cells, and eosinophils. White blood cell casts generally means pyelonephritis. Acute interstitial nephritis can be caused by infections, but also look for reactions to drugs, specifically antibiotics. And the ones you're going to really go after are trimethoprim sulfa, penicillins, and cephalosporins. And finally, acute tubular necrosis. An acute tubular necrosis is going to be caused by things that are in the tubules coming into contact with renal cells that are toxic, causing them to die. Now, a lot of things can cause that, but unlike glomerulonephritis and acute interstitial nephritis, where casts are really useful, in acute tubular necrosis, they aren't. And so what they might show you are muddy brown casts, but these are not sensitive nor specific. When you see acute tubular necrosis, think 2 things: ischemia, essentially prolonged or severe pre-renal. This is shock kidney, or exposure to toxins. And the 2 toxins you should pay particular attention to are going to be IV contrast and myoglobin. That is from rhabdo. When you see IV contrast and myoglobin and renal failure, the goal should be vigorous IV fluids. But there's something more about acute tubular necrosis you need to know, and now those are the 3 phases that you're going to encounter. If someone has acute tubular necrosis, you're going to see a prodrome where the creatinine rises. Then you're going to see an oliguric phase, where the urine output tanks. and you're going to be dialyzing fluid off of them because they're so overloaded. But then after the oliguric phase resolves, you'll have a polyuric phase, where the urinary output explodes. And instead of trying to remove fluid, you have to give fluid in order to keep up with it. Ideally, what you do is give IV fluids to prevent contrast-induced nephropathy or myoglobin-induced nephropathy in the first place. Now, that was long-winded, and it's going to be a lot less memorization from this point on, but I want you to see how you can take this simple framework and realize all the diseases that come into play. So when someone comes in with an elevated creatinine, what do? What are the diagnostic steps? And this is where pre-renal, post-renal, intrarenal comes in. If someone comes in with an elevated creatinine, the first thing you do is rule out pre-renal. Pre-renal is going to be assessed with a BUN to creatinine ratio, the urine sodium, the fractional excretion of sodium, and if they're on a diuretic of any kind, you can't use the FeNA, so you have to use the fractional excretion of urea. Now the things that tell you this person is pre-renal is a BUN to creatinine ratio greater than 20, a urine sodium less than 10, a FeNA less than 1%, or an FE urea less than 35%. If you have this profile, they are pre-renal. But you're not done, because if you say they're pre-renal, all that means is you had poor perfusion, and you don't know why. So be careful with this. If you say pre-renal and their volume down, you give intravenous fluids. If you say pre-renal and their volume up from one of those overloaded states, you give diuresis. Just because they're pre-renal does not mean give fluids. You have to use the history to decide that. But if these studies don't show you pre-renal, you then rule out post-renal. And post-renal is about obstruction, and you can do that with an ultrasound or a CT scan. And as we discussed, what you're looking for is hydro. Either hydroureter or hydronephrosis. The CT scan is better to be used to look for stones, but the ultrasound is better just to show you that there's hydronephrosis. If you have post-renal, you need to relieve the obstruction, and you can do that with a Foley catheter, if the level of obstruction is bladder or distal, a nephrostomy at the level of the ureter, or surgery. If it's not that, then you're left de facto with intrarenal. And very rarely do you need to go to intrarenal because often acute kidney injury is either pre or post. But what if their disease is intrinsic to the kidney? You're going to use the history and the physical exam to help you out a lot. And then you're going to look at a urinalysis. And that is going to be enough information most of the time to give you a diagnosis. And whatever that diagnosis is going to have a disease-specific treatment. For example, if the person is a diabetic and has glucose and protein in their urine, it's diabetic nephropathy. If they have hypertension and an elevated creatinine, it's probably from hypertension. But every once in a while, you might need to get a biopsy in order to prove what the diagnosis is. So I've done pre, post, intra because pre and post are easy to do with routine testing. Intrarenal is essentially a diagnosis of exclusion, and the only way to really diagnose it is with a biopsy that you're not often going to do because you don't want to stab someone in the back with a knife because of the bleeding risk if you can figure it out with a history and physical and a urinalysis. All right, we're going to close with, when someone has acute kidney injury, when do they need dialysis? What are the acute indications for hemodialysis? Those are A, E, I, O, U, which stand for acidosis, electrolytes, in particular potassium and calcium, intoxication with substances that can be dialyzed, and there's not many of them, overload, and uremia. Okay, This is the approach to acute kidney injury, pre, post, intrarenal. The urine creatinine, urine sodium, FeNA. Ultrasound. Intrinsic renal disease is diagnosed with history and the urinalysis. The list of potential diseases is long. Paying particular attention to the urine showing you casts that help you narrow down which intrarenal disease it is. That's acute kidney injury.